Thanks so much for that introduction and the participation in the program. It's a very important part of my professional career and my relationship with Dr. Townley, something I definitely treasure. And I'm in Seattle, as you mentioned, have been my whole career pretty much. I am focusing my comments on the history of Bicruciate knee on Dr. Townley because he clearly was the most influential and definitely was the first to pursue this area. Here's a bunch of the different predicates that you can see in the left lower hand corner is the most current thing that Dr. Townley got involved in, made by BioPro out Port Huron. They're doing that. Some of the others that are around also pictured. And there's a picture of Dr. Townley outside the OR. He did like to teach. He taught both in lectures and in the operating room. People visited him many times up in Port Huron, Michigan, where he practiced between 1950 and 2003. He was born in Minneapolis under humble circumstances. He went to high school and college both in Ohio. He went to college on a football scholarship. He actually was pretty good. And then he got into Ohio State University with the help of Mrs. McKee. She was the widow of a wealthy patron that he was connected with. He was working as a hotel bellhop and other odd jobs, but she helped him to attend Ohio State University. And there's a picture of him playing his collegiate football. He was a receiver, but he played a number of positions. He continued to follow football his entire life. He was very interested in it, and he had a good friend, Mike Mandarino, who was not only a player for the Philadelphia Eagles and an orthopedic surgeon as well, but also kind of an influential orthopedic surgeon in Dr. Townley's inner circle. Dr. Townley did his residency at Ford. It was interrupted by service in World War II. You can see there's a gap in there. He went to Fort Dix to work at Tilton Hospital, kind of in the middle of his residency. That was a good thing for him. He got to do a lot of surgery there, involved his ideas, and then when he came back to Ford, he had a lot to contribute. He made this drawing, and this sits above my dictation area in my office, the original hand sketches. They're in pencil, and they've been preserved. His view of the total knee in the future that he was going to build. This is just his ideas at that point. It is a Bicruciate design, as you can see if you look at it carefully. He showed it to John Charnley, who came to town to Detroit to talk about positive pressure arthrodesis of the knee, and John Charnley said it was too much metal, so Dr. Townley went ahead with just the tibial part, and there it is, and he started implanting that in 1952 and continued to implant all through the 1950s, 60s, and stopped in about 1971 using it. That was written up by Len Marmer, who was a friend of his in clinical orthopedics a number of years later as a significant contribution. And I put this slide in there from the Merrill company. Today no one would know what that is, but this is a company that made one of the first acrylics. It made a product called Ostomer, which was something like methyl methacrylate. It was a bone glue, and Mike Mandarino, who was a friend of Townley's, used it to glue non-union fractures together. And I show this slide. It shows the Townley articular plate, and then you can see a metal resurfacing on the patella, which that design is from Dr. Duncan McKeever, who was a friend of Dr. Townley's. And that particular knee, he had metal on the patella, metal on the tibia, and he put this Ostomer acrylic on the entire femur. It's a Bicruciate design. So this is the first Bicruciate knee that was done, and this was done in 1959. And he didn't say anything about it or report it in any way. I have the films and a few very long-term follow-ups. It did perform reasonably well, but the acrylic degraded in the body, and it went back to functioning as two hemiarthroplasties, basically. Dr. Townley remained interested in polyurethane, and he took it up again in 1996, made polyurethane again, and it's had some clinical application, mostly over in Europe. He made his anatomic total knee, and this time with polyethylene on the tibia, and put the metal surfaces on the femur and a polyethylene surface on the patella. And he first started implanting that particular device in 1971. This is actually it's a picture that was on the cover of a journal, a nursing journal in 1974, was his first actual publication, although he did have an abstract published in Clinical Orthopedics in 1973 describing his first 80 cases of a polyethylene on metal total knee bicruciate retaining. This is a picture when he tried hard to get industry to pick this up. It wasn't very successful at first, but in 1972 he was. And this is from a DeFew brochure where they agreed to manufacture and distribute it. It's an all polyethylene tibia at that point. And those principles that are listed there about anatomic orientation, ligament preservation, simple instrumentation, he did not change these principles through his career. This is a drawing that I had made to illustrate a paper that I published in 2015 in Clinical Orthopedics related research, talking about a 23-year outcome study. Everybody in that paper had more than 20 years of follow-up. It was a pretty enthusiastic report. You can see it hasn't changed much. Horseshoe-shaped tibia, pretty uncomplicated femur, preservation of the cruciate ligaments. This is a sketch. Again, this is from 1980. You can probably make that out a little bit. It's a mobile bearing bicruciate knee. A friend of Dr. Townley's is Fred Beagle, who I actually got a text from this morning from New Jersey, and who actually pursued it, a mobile bearing bicruciate. Townley never made this device, near as I can tell, or implanted it, but he thought about it, and so did the manufacturer, and they did later make it, and they called it a meniscal bearing. When I met Dr. Townley in the 1980s, we made some modifications, and he established the BioPro company, and by then it was a cementless knee. Principles remain the same. Horseshoe-shaped tibia, bicruciate retaining. He didn't exclude people based on deformity, of course, because he had all comers, and many of the patients were very deformed. That's one of them. That was a professional golfer that he did in 1976. He trued up the tibia, an all polyethylene cemented tibia, and then he put some screws to kind of support the deficient medial condyle. You can see some stress reaction in the fibula as he shifted that out of tremendous varus into valgus. This is one of his original slides, and I think this is an important principle to grasp, that you don't have to let the cruciate ligament go, and it's just a concession that you're going to have an improper joint if you do. It's something that Dr. Townley felt, and I think many of us tonight will say, well, that's something done for convenience. It is we do have to consider it a concession if we remove somebody's cruciate ligament. Certainly never do it on a normal knee. Wonder about doing it on a replaced knee. Dr. Townley did asymmetric tibias when needed, and on the right you can see a real dramatic example of the hemiarthroplasty with very different issues. But on the left, that's a bicruciate knee with only a 2 millimeter difference. Now, that was fairly common in the early going. He later felt he could balance the knees, so that wasn't much of a need, but they were often asymmetric, the thickness of the medial versus lateral compartment, usually the lateral being a little thicker, which is typical of a normal knee as well. Alignment was critical. Dr. Townley said he used mechanical alignment, but he really didn't. If you look at his drawings, they're kinematically aligned by our current definition of how a knee would be. This has got a chain, but if you operated with him, he often just used a Bovie cord, and he had very simple instruments. But he was very proud of the orientation that the knees had, and called them surgical misadventures if he didn't achieve that. The flexion was limited because these were symmetric polyethylenes. They didn't roll back in the lateral compartment. He never had the availability of that. For its time, it was considered relatively good, in fact quite good, because the typical knee of the era that he worked in had flexion of maybe 110, and the Townley knee, the average flexion of his design was 117. So it was pretty good. Not by today's standards, but certainly for its era, it definitely was. This is another view, a couple of Townley Bicruciate knees. He did become the president of the Knee Society, and gave a pretty persuasive address in 1989, although the moderator that followed said that only God and Dr. Townley could get the Townley knee in correctly every time. I'm not sure that was true. There was a picture of him about that time when he was president of the Knee Society. This is the most latest version. It's the one I used hundreds of times. It was the subject of the paper I published in 2015. And we published several different papers, comparison studies, using this exact model. It had a metallic keel because breakage of the tibial part of the knee could happen. It was supported by that, and that reduced the incidence of that. Pretty uncomplicated and very unconstrained design. People would ask, well, wouldn't the cruciate ligament fatigue and fail over time? And this is again a picture of one of Dr. Townley's slides 20 some odd years later. No sign of that. I don't see that happen very often in my late-term follow-ups either. So he practiced until 2003, and if you add that up, when I said he was born in 1916, he was 86 years old when he did his last operation. So he had a very long and fruitful career. He died shortly after he stopped practicing. He did 240 cases that last year, however. That's a picture of Dr. Townley and I in front of the Townley clinic in 2003. There's another photograph of him in his teaching. He did like to teach. He would spend as much time with somebody as they asked for him to spend. When I first met him as a resident, he spent over an hour with me. I was just some resident that he'd never heard of. It was great to be around. A lot of fun, too. He had a great way of talking, told a lot of funny stories. He made an artificial cruciate ligament, and I'm not sure if he supported some of his deficient total knees with it, but I know he thought about it, and this was commercially available. He spent a few years about this artificial Townley ligament, mostly for the ACL. These are his characteristics, and very high energy guy. He loved all aspects of orthopedics. He didn't just do knees. He did hips and shoulders and anything that would come his way. He was never satisfied. It was tough to do this presentation on history. He always liked to tell you what he was going to do rather than what he'd already done. He was an environmentalist. This is a picture of my driving his electric car back in 2003. Thanks so much for listening to Mr. Bicruciate knee. Started in 1959, originally in our current form in 71. Thanks.
Dr. Pritchett, that was excellent. I have a question. What would Dr. Townley do if he ran into an ACL that was not there? If it was an ACL deficient knee, how would he approach it?
You know, he would do his bicruciate knee anyway, almost always. He had other options available, but he was so skilled at recreating the joint line, the balance of the knee, and the other characteristics, it would bother him that it wasn't present. He would say it wasn't going to be as good because of the patient wouldn't have what he thought was the proprioceptive feedback. But he typically did that anyway. But you know, any little nubbin, any fiber at all, he thought had some value. So he typically went ahead with it, and he certainly did in his early days because that was the knee that he had. And his results, admittedly, were not as good. I looked at some of the cases because he did keep track of that, and they didn't function quite as well, but they functioned reasonably well.
Excellent. Thank you very much. That was really interesting, your talk.